because this is actually a very critical point. And so here's the deal. Being a young associate in a practice is much, much harder to practice clinical dentistry than being the owner, because because even if you're a superstar dentist, young dentist, you have your BMW, in a 3M series. You can take it to a racetrack, but the owner is blocking you in front of you. You can't go any faster than the owner. Okay? You are only as good as the owner. Okay? And that is the frustration of a young doctor, oftentimes. At least the people who have gone through my training, my residency, you know, they're going to come back and say, but Dr. Lee, this is what they do, and da 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 da. Okay. So, number one, the reason why most patients, I shouldn't say most, many patients have poor compliance with hard acrylic night guard is because the dentist who provided for them didn't know how to deliver it properly. Just as crowns, we don't just give the patients crowns, do we? We have to fit it for them. Night guard has to be fitted for them as well, especially hard acrylic night guard. It is actually dental school's fault that most dentists don't know how to do hard acrylic night guard, because dental schools have zero requirement for learning how to do occlusal night guard, right? Yeah. Every dental school. I know, over the years of running the program at UCLA, okay, I've run into probably at least 30, 40 different dental schools, graduates all over the world. Okay. Thank you, Dr. Mylene. Okay. Okay. All right. So, so the reality is not one dental school has a requirement of learning how to do occlusal guard. My experience with occlusal guard was just like yours, learning how to make a sports guard, soft night guard from my dental school. And my dental school soft night guard had no consideration for occlusion. It was just a suck down. Here it is. Good luck, right? The only reason why they have better compliance is because they are able to clench into it. The hard one they can't because it's uncomfortable. But the problem with soft night guard is a sports guard is you can't equilibrate the occlusion. Okay? And this is the pitiful state of dentistry. This is the dirty secret of dentistry. And this is something we can't say to my patients, right? If I'm saying that to my patient, I'm spitting laying down on my back. I'm spitting at myself because I'm just painting the entire dentistry being wrong. Okay? So you're right. Okay. Now, one way you can do soft night guard if they are lab fabricated, soft night guard, okay, that can come a little bit closer to what we're talking about, okay, is you can use, it takes a little bit of initially little trepidation, but is you get yourself a hot alginate bowl of water, okay, before you deliver it to the patient. Make sure it fits properly, reasonably well, okay. And then what you do is you get a hot torch, alcohol torch or butane torch. And then you grab your occlusal guard, let's say, I don't have any sample, occlusal guard, you by the front, okay? And the posterior, bicuspid and the posterior region, you heat it up. Just like Dawson talked about the wax rim, the wax bite registration. You heat up on the side, okay? And then when you heat it up just enough, not to the point where it starts to deform, just the occlusal surface area. It starts to get a little soft, the EVA material they use for this. And then what you do is you temper it in hot water, put it into the mouth, and then you guide them into CR and you have them bite down. And what's going to happen is you're going to see the molars have more indentation. And as you come to the bicuspid, you have very little indentation. And because you didn't heat up the front part, there is no indentation in the front whatsoever. So front part is going to act as an anterior stop in case if you warmed up the posterior too much. Now you have somewhat of at least evened out soft night guard. You don't have anything that's standing out, acting as a interference.
So the goal is to try to get bilateral
Exactly,
balance
exactly.
height,
There
right?
you go. Occlusion, whether it's with teeth, whether it's with implants, whether it's with partial denture, whether it's with night guard, if you give them something resembling bilateral posterior stop,
Mhm.
that becomes more stable.
And nothing on the anteriors, right?
Anterior, if they touch, I don't have fundamental problem with that,
Mhm.
but it cannot be taller than the back.
Yeah. Mhm.
And by the time we get to the long centric idea, you realize a lot of times you can't tell who requires the long centric or not. So if somebody requires long centric, and if the front teeth are touching same time as the posterior, that means by definition that person's anterior teeth are in interference.
Mm.
That's the problem with anterior teeth touching. If you only have bilateral contacts, you are able to give them stable bite. You don't need anterior for the stable bite. Now, in part of our vertical dimension discussion, Dawson talks about, okay, if the front teeth are not touching, they're gonna super erupt. And I wanna spend good time rebutting against that next time. And that's why I stopped here, because that requires decent amount of discussion to why I think that is a false observation. But in the meantime, what you have to do, Chris, I think, I'm assuming you can go by Chris also, Christine, Chris, okay?
Doesn't matter.
Okay, it is this, that, that you have to bite your tongue at your practice,
Yeah. Yeah,
okay? Because you don't want to deviate from your ownership too much,
right.
okay?
But is there any indication for soft night guard at
Sports
all?
guard,
Just when you're doing, okay,
sports
sports
guard,
guard.
yeah. Oh, and or in a dental office, you somebody is in true a lot of pain, they really need something, and you need time for the lab to turn it around. Even if you're doing in-office printing, you need time to make that. You want to just do a quick suck down, I guess.
Okay.
So to me, that's more like placebo effect than anything else.
Yeah, okay.
Okay, but in my practice, I don't even do hard soft bilayer night guard. It's all 100% occlusal guard.
Mm.
Yeah. Bilayer is, yeah, you know what? If they don't have any TMJ problem, bilayer is probably acceptable. But you still have to adjust their occlusion, calibrate their occlusion. And
So
that's the part
another,
that most dentists are too scared to do, to
yeah,
calibrate their occlusion.
yeah.
Somebody was saying something.
Another thing,
Yeah.
like I just feel like we're handing out these night guards left and right. Like every time someone says, "Oh yeah, I think I'm clenching," or as like, if we see any type of wear, we're like, "Oh, let's get you a night guard." But I still don't understand like in the actual indication. Like just because they're clenching, does a bite guard or hard night guard does it help, or
So
is
hard
there?
night guard will do several things. Okay. Number one, it does provide physical protection against the teeth wearing away.
Mhm.
We have to assume that you did a reasonably good job calibrating the occlusion. Because if you don't do that, then all bets are off anyway. Okay. So assuming that it was reasonably well calibrated and delivered, number one, it does provide a physical protection. Number one. Okay.
Yes.
Number two, okay, if it was well calibrated, it does deprogram your jaw muscle. And if it deprograms your jaw muscle, oftentimes, and if you do a follow up adjustment, then oftentimes they will not clinch as much because their clenching is a response, oftentimes, besides stress. Stress in itself is good enough to clench, but from a dental perspective, clenching is oftentimes a follow up response to sliding or uneven bite. So when you equilibrate that, that does create stability.
When you're saying equilibrate, are you talking, you're talking
I'm
about
not
the,
talking about teeth. I'm talking
okay,
about just splint equilibration,
okay.
calibration. Thank you. Thank you for clarifying that. But here is the caveat to that clinching part, and that is this. And Dawson talks about it in the vertical dimension discussion. If you elongate the muscle too much, meaning if you open up somebody too much, then the muscle wants to go back to its original length.
Mm-hmm.
So if you have somebody whose vertical dimension was, let's say, ideal, it was not collapsed, it was ideal. And if you give them splint that's too thick, then you're actually inviting them to clench because even if everything is equal, because their muscles want to go back to like unstretched point. So in some patients,
Yeah.
you have to accept the fact that they are going to clinch, even with the night guard. Okay?
Would you get what? Why would you give the night guard in that case then?
Because it still provides physical barrier where their teeth are not grinding against each other.
Because there was a time when I had to deliver and
Mhm.
everything was fitting fine. It looked like bilateral, but then they couldn't close their lips because I could tell like it was so
It was too
thick.
big, too thick.
Yeah.
Exactly. So a certain thickness is indicated. Theoretically, you don't want your splint night guard to be any thicker than it has to be. So they will say theoretically 1 millimeter molar disclusion. Easier said than done because by the time you're done adjusting everything, right? If you start out with 1 millimeter, you're gonna perforate,
Yeah.
right? So you start out with something like that's why I said like 3 millimeter, but then sometimes the lab makes it 5 millimeter, right? And then if you want to try to make that down to 1 millimeter, oh my God, that can take an hour, right? So it takes time, So this is why it's not an exact science, okay? So, but if I provide physical barrier and if I provide deprogramming purpose, to me that is good enough for most people, okay? Now there is one more benefit to that, and that is if I do the deprogramming, oftentimes I can get their true CR. And it becomes much, much easier for me to manage their occlusion in the long run. As I'm doing each tooth at a time, I can get it into a little bit closer to CR, a little bit closer to CR, and their overall occlusion gets so much better. So my way of occlusal management is not 1 or 2 or 3 time or 5 time visit. It is as long as they're with me, I am going towards optimizing their occlusion. And in that sense, having the splint therapy makes sense. Okay. When we talk about the vertical dimension, a lot of these concepts coming, will be in play. Okay. So when they talk about don't open people's bite any more than you have to, I agree with that because to a certain extent, I want some room for my night guard. And
Hmm.
then also, if somebody is already too open, night guard will not be good for them, no matter what. So there are some situations where I will not give them night guard initially. I have to bite the bullet and go in and do some adjustment
Mm.
to bring them down first. Okay, Mari, I didn't mean to ignore you, but you raised your hand earlier.
No, it's fine, sir. I think she was not there with us from the beginning
Yeah, yeah, yeah.
when we were talking about even the periodontal situation effect from the clenching and fremitus, and the idea of having a equal bilateral at the same time. So when they close, they touch, they have a simultaneous touch at the same time, which is gonna lead us to the equilibration of the night guard. So most of the patients that they're clenched, if you look at their teeth even closely, you see you check fremitus and then you check for other signs like recessions, other things. All these things are night guard or the occlusal splint therapy is gonna be helpful with. But on the other hand, if you give them the soft one, you're not gonna control the direction of the force, as in have the contact stable and centric and dynamic movement as you do in the hard night guard. So their fremitus, their recession are still ongoing. It didn't fix anything except for giving them a barrier um, to protect their teeth from getting attrition. And their muscle are not going to be deeper ground because the soft night guard, as Dr. Lee mentioned, it's going to give their brain a signal. There's something soft. You need to keep chewing, firing
Yeah, they actually,
more
it
than they
stimulates them to
used to.
clench more.
Yeah,
Yes. So,
if
and the
that,
one more thing also, that's something that people don't think about is this. You give them soft night guard, if they're truly wearing it, they usually don't last more than a few months or at most like a year or two because they grind it away. Do you think they're spitting it out while they're sleeping?
It does
No.
happen, I think.
Well, yeah, but so a lot of times you have to assume they're swallowing that stuff,
Mm, okay.
right? So
Yeah.
so you have to ask yourself, is that something that I want for my patient? No. So those are all the little things. But really, the truth of the matter is most dentists uh, uh, use default to soft night guard because they don't know how to do hard night guard. That's the truth, and that's a shame, you know. And so, like for example, if I gave somebody a partial denture replacing lower left quadrant, if a patient was missing 18, 19, 20, 21, and patient couldn't afford implants, so I give them a partial denture. And at nighttime, I tell them to take the partial denture out when they go to sleep. How is the patient's occlusion going to be stable when they occasionally clinch? It's not. Their joints are always going to be screwed up. So in my practice, I actually give them a night guard so that when they take the partial out, that they have an occlusal stability still. Now you can have them get the same effect theoretically, just have them wear the partial to sleep. But my guess is if it's at least cast partial, uh, you know, there is a lot more effort for redoing the partial when the partial teeth wear out too fast. You know, because with hard acrylic night guard, what I often do is I can actually add on to the occlusal table if they do wear away. If I grind away too much, I can add on to it again using jet acrylic or alike acrylic or any of the orthodontic acrylic. With anything soft or even semi-soft stuff, you cannot do that. And then also same thing. Let's say if you have somebody wear a sports guard on number in the upper, and let's say I did a crown on uh, number 3. Well, you know that the shape of the new crown is not going to be the same as the previous crown. So the only now, because they're soft, they'll accommodate it a little bit. But if they're way off, you don't have any means to adjust that. You just have to make a new one. Well, with hard acrylic, I can actually adjust it like denture, and I can even reline inside if I need to get it to have a better fit. Okay, so it is. I think you know, um, you know, you know, uh, sports guard is definitely helpful. There's no doubt about that. And in that sense, I guess many times, if your occlusion is stabilized on the sports guard, it's better than not wearing one, but it's certainly not ideal over hard acrylic night guard. Okay, everybody, that was a good discussion. Thank you so much. I will see you next month, I